Peds Gastrointestinal Disorders 1. Vomiting. The major concerns when a child is vomiting are the risk of dehydration, the loss of fluid and electrolytes, and the development of metabolic alkalosis. Additional concerns include aspiration and the development of atelectasis or pneumonia. Causes of vomiting include acute infectious diseases, increased intracranial pressure, toxic ingestions, food intolerance, mechanical obstruction of the gastrointestinal tract, metabolic disorders, and psychogenic disorders. Assessment. Characters of vomitus, signs of aspiration, presence of pain and abdominal cramping, signs of dehydration and fluid and electrolyte imbalances, signs of metabolic alkalosis. Interventions for vomiting. Maintain a patent airway. Position the child on the side to prevent aspiration. Monitor the character, amount, and frequency of vomiting. Assess the force of the vomiting. Projectile vomiting may indicate pyloric stenosis or increased intracranial pressure. Monitor strict intake and output. Monitor for signs and symptoms of dehydration, such as sunken fontanelle, non-elastic skin turgor, dry mucous membranes, decreased tear production, and oliguria. Oliguria is no wetting, no urine. Monitor electrolyte levels. Provide oral rehydration therapy as tolerated and as prescribed. Begin feeding slowly with small amounts of fluid at frequent intervals. Administer antiemetics as prescribed. Assess for pain or diarrhea. Advise the parents to inform healthcare provider if signs of dehydration, blood in the vomitus, forceful vomiting, or abdominal pain is present. Diarrhea. Acute diarrhea is a cause of dehydration, particularly in children younger than 5 years. Causes of acute diarrhea include acute infectious disorder of the gastrointestinal tract, antibiotic therapy, rotavirus, and parasitic infestation. Causes of chronic diarrhea include malabsorption syndromes, inflammatory bowel disease, immunodeficiencies, food intolerances, and non-specific factors. Rotavirus is a cause of serious gastroenteritis and is a nosocomial, means hospital-acquired pathogen that is most severe in children 3 to 24 months of age. Children younger than 3 months have some protection because of maternal acquired antibodies. Assessment for diarrhea. Character of stools. Presence of pain and abdominal cramping. Signs of dehydration and fluid and electrolyte imbalances. Sign of metabolic acidosis. Intervention for diarrhea. Monitor character, amount, and frequency of diarrhea. Provide enteric isolation as required. Instruct the parent in effective hand washing technique. Children should be taught this technique also. Monitor skin integrity. Monitor strict intake and output by weighing the diaper before and weighing it after. Monitor electrolyte levels. Monitor for signs and symptoms of dehydration. For mild to moderate dehydration, provide oral rehydration therapy with Pedialyte or a similar rehydration solution as prescribed. Avoid carbonated beverages because they are gas producing and fluids that contain high amounts of sugar, such as apple juice. For severe dehydration, maintain nothing by mouth status to place the bowel at rest and provide fluid and electrolyte replacement by the intravenous route as prescribed. If potassium is prescribed for IV administration, ensure that the child has voided before administering and has adequate renal function. Remember, before administering potassium, ensure that the child has voided before administering and has adequate renal function. The major concerns when a child is having diarrhea are the risk of dehydration, the loss of fluid and electrolytes, and the development of metabolic acidosis. Cleft lip and cleft palate. It's a vitamin A deficiency also, more often seen in Asian, Latino, and Native American. Description of cleft lip and cleft palate are congenital anomalies that occur as a result of failure or soft tissue or bony structure to fuse during embryonic development before the 3 months, during 3 months of pregnancy, or even before during embryonic development. The defects involve abnormal openings in the lip and palate that may occur unilaterally or bilaterally and are readily apparent at birth. Causes include hereditary and environmental factors, exposure to radiation or rubella virus, chromosome abnormalities, and teratogenic factors. Closure of the cleft lip precedes a closure of the cleft palate and usually performed by age 3 to 6 months. Cleft palate repair is usually performed between 6 and 12 months of age to allow for the palatal changes that occur with normal growth. A cleft palate is closed as early as possible to facilitate speech development. It's called palatologies. A child with cleft palate is at risk of developing frequent otitis media, means ear infection. This can result in hearing loss. A multidisciplinary team approach including audiologists, orthodontists, plastic surgeons, and occupational and speech therapists is taken to address the many needs of the child. Assessment. Cleft lip can range from slight notch to a complete separation from the floor of the nose. Cleft lip can include nasal distortion, midline or bilateral cleft, and variable extension from the uvula and soft and hard palate. Interventions for cleft lip and cleft palate. Assess the ability to suck, swallow, handle normal secretions, and breath without distress. Assess fluid and calorie intake daily. Monitor daily weight. Modify feeding techniques. Plan to use specialized feeding techniques or burators like big nipples and special nipples and feeders. Hold the infant in an upright position and direct the formula to the side and back of the mouth to prevent aspiration. Feed small amounts gradually and burp frequently. Keep suction equipment and bulb syringe at the bedside in case of aspiration. Teach the parents special feeding or suctioning techniques. Teach the parents in the ESSR method of feeding. E for enlarge the nipple, S for stimulate the sucking reflex, S for swallow, and R rest to allow the infant to finish swallowing that has been placed in the mouth. Encourage parents to express their feelings about the disorder. Encourage holding infant and calling the infant by name. Post-operative interventions for cleft lip repair. Provide lip protection. A metal appliance or adhesive strips may be taped securely to the cheek to prevent trauma to the suture line. Avoid positioning the infant on the side of the repair or in the prone position because this position can cause rubbing of the surgical site on the mattress. Position on the back upright and position to prevent airway obstruction by secretions, blood, or the tongue. Keep the surgical site clean and dry. After feeding, gently cleanse the suture line of formula or serosangrinous drainage with a solution such as normal saline or a designated by agency procedure. Apply antibiotic ointment to the site as prescribed. Elbow restraint should be used to prevent the infant from injuring or traumatizing the surgical site. Monitor for signs and symptoms of infection at the surgical site. Cleft repair, palate repair, post-operative interventions. Feedings are resumed by bottle, breast, or cup per surgeon preference. Some surgeons prescribe the use of a septo syringe for feeding or a soft cup as a sippy cup. Oral packing may be secured to the palate. Do not allow the child to brush his or her own teeth. Instruct the parents to avoid offering hard food items to the child, such as toast or cookies. Soft elbow or jacket restraint may be used to keep the child from touching the repair site. Remember to remove restraint at least every 2 hours to assess skin integrity and to allow circulation and to allow for exercising the arms. Avoid the use of oral suction or placing objects in the mouth, any object in the mouth. Avoid anything in the mouth, such as tongue depressor, thermometer, straws, spoon, forks, or pacifier. Even pacifier, don't put them. Provide analgesic for pain as prescribed. Instruct the parent to monitor for signs of infection at the surgical site, such as redness, swelling, or drainage. Encourage the parents to hold the child. Initiate appropriate referrals, such as dental referrals and speech therapy referrals. Esophageal artesia and tracheoesophageal fistula. Esophageal artesia and tracheoesophageal fistula. Description: the esophagus terminates before it reaches the stomach, ending in a blind pouch, or a fistula is present that forms an unnatural connection with the trachea.